The chairpersons are Dr. Samir Pancholy, Dr. Justin Paul, Dr. Pintu Nahata, Dr. Sharad Jain, and Dr. Hasit Joshi. Our first lecture will be by Dr. P.K. Sahoo.
A very good morning to everyone. In fact, I have been assigned to talk on the role of IVUS step by step. So this is something very basics that I'll be talking on, how to do a IVUS guided intervention step by step. Because it is very important, because it is just not pushing a catheter inside and then taking it out. We have to see what is to be done. So there are 5 points that I'd like to highlight how we go step by step. First, study what is the plaque morphology. Does the plaque need any modification? How to size your device? Is your stent optimized? And finally, have you really done any complications, or you have come out safe? So coming to the first thing, what is plaque morphology? Now there are 3 basic types of plaque: the soft, fatty, fibrotic or calcific. And there are 5 types of complex plaques: dissections, rupture, thrombus, erosion, hematoma, true and false lumen. Now let us see the 3 types of this thing, that is, either these plaques may be concentric or eccentric. There may be a soft plaque, as you see like this, a fibrotic plaque, or that it may be calcium. So whenever you see the plaque in a first step, try to find out what is your nature of the plaque, what is the distribution and what is the characterization. After this, if you see the gray scale, there are 3 types of plaque, as I said, the fatty, fibrous and calcific. Plus there may be a combination of fibrofatty, fibrocalcific or a mixed plaque. So first step is to classify what is the type of plaque. Then you go to the next step: does this plaque need modification? Now what do I mean by modification? If I see from this spectrum to the other spectrum, that is hot fatty plaque, you can just optimize the stent by doing a predilation in the balloon. As we go further to the fibrotic plaque, because these are the plaques which there is slippage or there is plaque shift. So you have to use devices like cutting balloon and other devices, especially oscillations. And once you have a calcific plaque, you will start thinking of atherectomy or IVL. Now, calcification is an area which everyone has interest in, because this is the most difficult thing. People have previously classified as how many quadrants. If it is less than 90 degrees or 1 quadrant, it is mild. If it is 90 to 180 degrees or 2 quadrants, it's moderate. If it is more than that, it's severe. This is one way of classifying it. Or you can classify as superficial, deep. In superficial, you can see the denervations, because based on this, you can know whether you just do a rotablation or you go for any further plaque modification technique. Now then comes the calcium score. This calcium score on IVUS is a little bit cumbersome compared to what is in OCT. Now this scores calculation done from a point of 0 to 4. If any of these points out of 4 factors, like calcium more than 270 in more than 5 millimeter square is more than 270, 1 point, 360 degrees 1 point, nodule 1 point, and vessel diameter less than 3.5, this is 1 point. So based on these 4 points, you have to think of how to score yourself and consider atherectomy. What has been shown is that the stent expansion is much better when you do an atherectomy, rather than just going on opening up balloons and using them, and finally you land up in problems. I'll just give an example. Let us see the first this thing. You see the circumferential calcium is almost 360, so I give it a 0.1. Then you see that the length of the calcium is 26, so I give it another point. The vessel size is more than 3.5, so it's a 0 point for here. And there is a calcific nodule, so it's a 0.1. So these are the 4 factors that has to be considered while giving a calcium scoring. And finally, the calcium score is 3. So we have to do some form of calcium preparation. This is very important. So this is the next step that we have to do. Then coming to the complex images, as I said, there are 5 complex images that you can come across. Because IVUS is very easy, because you have to just think of 3 basic images, 5 complex images. You can cause a dissection, a plaque rupture, a thrombus, a hematoma, or a false lumen. So look out for these 5 complex features on your, after you have debulked or you have done your preliminary preparation of the plaque. Now, for example, this is a dissection. You can see that a dissection has occurred over here, and this is something that one should not miss, because you have to decide whether this dissection is to be tackled or left alone. Now, for example, you can evaluate also plaque erosion and plaque rupture. It is very easy to know erosion on OCT, but HT IVUS does help us, because if it is an erosion, then we do not have to stent it, but if it is a rupture, then we have to think of stenting it. Now, I'll show you cases of plaque rupture. Now, these are cases of plaque rupture where one has to think of stenting the case rather leaving it alone, because these patients are more prone to have further events. Now, for example, this is a case where you can see that a rupture has taken place. It is exactly a cavity inside another cavity. This is what you see on an HT IVUS. Now, these are the cases which cannot be left alone. This has to be stented and has to be dealt with. Now, thrombus. Thrombus is also very important to identify, because so that you do not miss what is it. See a large chunk of thrombus coming here, and it is easy to identify, especially when you use the 60 megahertz IVUS catheter. Now, this is a case of erosion, and you can see the thrombus over here. And these cases, there is no need to go ahead with a mechanical a stent. Just pharmacotherapy or intracorneal lytic will do the job. Now, hematomas are very common when you dilate, and this also you should know. You should be very clear about whether what has happened to hematoma. If it's a large hematoma, you might need to require a cutting balloon to debulk the hematoma and finally put a stent. Now, this true versus false lumen is very important, because what happens when your wire goes through the false lumen, then you will see two lumens over here, and I'll show a case where there is a true and a false lumen. You have to see the intima, which will tell you an idea about where you have gone and whether you are in the false or the true lumen. The third step is how to size your device. After we have known the plaque morphology, we have known the basic morphology, we have decided what will be the modification pattern. Now we go to what will be the size of our device. Now, always first see the two ends, the distal and the proximal markers. You measure them. Based on it, if you're using a balloon, take a balloon 0.5 millimeter under average proximal and distal reference. If you're using a cutting balloon, take an average as a proximal and distal reference. If you're a stent, again, it follows the rules of the cutting balloon, the average of the proximal and distal reference. So take the normal segment, see it in IVUS, measure it, and then size your device. Now, for example, this has got a proximal reference, this has got a distal reference, and you know what is the distance that you have to cover. There is a calcific nodule over here, it has to be prepared, and finally we have to choose our stent size. So this helps in lesion length and finally choosing. So, this is an example of the proximal and the distal and how you choose your stent size, so that based on your measurements. Now, the landing zones are very important, because you cannot land in a part where the plaque is there, because that might be a plaque rupture or plaque shift, and that is very important. So when you start dilating the stent, you have three strategies. Either you go to a lumen to lumen, which is the least aggressive, go for a mid-wall to mid-wall, that is midway, and go for a very aggressive dilatation of media to media. What I follow in my practice is to go for the media to media, so that you get a good outcome and a large vessel. Now, optimal landing zone should be anything less than 50% of the stenosis, because it may be a diffuse disease, so you do not have to stent the full thing. Try to keep it at where the landing zone is less than 50%. The fourth step is your stent optimized. That has to be seen. Now, how do you optimize a stent? It is very easy to optimize on OCT, because it gives you AI calculation that so much percentage has been dilated. But here you have to do a little bit of manual work, whether the proximal, at least more than 90% of the vessel size, the stent size goes accommodate more than 90%. And this is what happens. You see the luminal size and try to optimize based on the normal area of the artery. You try to see how much you can optimize to the maximum. Illustrative example, because you see the proximal luminal reference is 9.71, and we have dilated to 9.69, so it is 99% expansion. So this is a good expansion. Anything you get more than 90%, we call it a good expansion. The same holds true for a distal expansion also. For example, it was 5.52 in the normal healthy segment, and here we have achieved 5.01, which is a 90%, so this is ideally done. So here you have to do a little bit of work. You have to ask your tech to calculate the normal segment and see that you do a 90% dilatation. The last step is, have you done any complication? So now this is what happens. Truly speaking, two complications are very common: the geographic miss and the edge dissection. So be careful about the geographic miss, because if you miss it, these are the areas where restenosis will occur. And if you get a stent edge dissection, this may thrombose and may cause problem. So this is a case where you can see the proximal vessel and the distal vessel. There is no geographical miss, no edge dissection. So this is the last stage that you have to see whether you have missed anything, geographic miss or edge dissection. Now what do you mean by edge dissection? If the lumen area narrowing is less than 4 millimeter square or the dissection angle is more than 60 degrees. For example, you can see this, the angle is quite wide. There is a large dissection here, and also the lumen area has also reduced. So these are the edge dissections which you cannot leave. Of course, it has been shown that low-grade angiographically and silent edge dissection need not be tackled, but these two figures are to be remembered. When the luminal area becomes less than 4 and dissection angle is more than 60, you have to think of stenting it. Two issues, under-expansion versus malapposition. Under-expansion is like this, that your body is less, but you're wearing a large side trouser, and this is often a technical one, usually occurs in hard eccentric lesions, and there is a regional stent weakness. So you have to be very careful, and in malapposition, it is as if one side of your trouser is not fitting you. So you have to see how many struts, at least 200 micron struts. Gap should not be more than 200, but it's very easy to detect on OCT, but it can be detected also on IVUS very clearly. For example, let us see this case. Is there any malapposition? No. But if you see the next diagram, you will see that there is definitely a malapposition, and you can see the stent has not apposed properly. So here is this thing that you have to start post-dilating it so that we can get a better result and we don't leave our stent malapposed. Now, what is incomplete stent apposition? Incomplete stent apposition is that when the lumen wall is approximately 10% of the stents have not apposed. So that is the ISA, incomplete stent apposition. You can see this case in where there has not been well apposed. So we are dilated at a very high pressure. Now you can see that it is well opposed. So acute instant thrombosis can occur when you leave a stent incompletely opposed. So one has to be careful that you see if there are 4 quadrants, at least 1/4, less than 1/4 of the quadrant is not opposed well. So you go ahead and finish your job. Now, does IVUS help? Yes, it helps in post-dilatation needs. Pre-stenting, stented, it is underdilated. So we have to post-dilate it and choose what is to be done. Now, the role of port has been well established that when you're doing a left main stenting or a bifurcation stenting, IVUS will give you an idea what would be the port size balloon and how much length you have to see, and what was before port, you can see after port, and then you can finally dilate it. Now I'd like to go few real life scenarios where we'll see how IVUS has helped. So these 5 steps have to be followed when you do it. Find the block morphology, designate modification, size your device, optimize your device, and finally see whether you have done any complication. Let us see certain LMCA disease. Now in LMCA disease, people have used OCT, but for especially ostial lesions or all throughout the LMCA, the IVUS is something which is very useful. Now there is a criteria which you all know that we have to try to achieve at least 7, 6, 7, 8, 9, 10 for the post-Excel criteria and try to achieve it, and this is very clearly visible because large vessels are not visible on OCT. These vessels are very well visible on an IVUS. Now, LMCA shaft disease, for example, this is a case of a shaft LMCA with a LAD lesion, and a pre-IVUS was done where we could see a very fibrotic lesion over here. So once we saw a very fibrotic lesion in the LMCA, the first thing was next step was to go for a cutting balloon. And that is what we did. The steps of the PCI were that we finally did a single stent strategy. And if you see the post-cutting balloon listing pictures, it gives you a very good idea that your cuts have been very well demonstrated. So when you demonstrate these cuts, it gives us an idea that my stent will now expand properly. That is most important. So that is again the rewiring of the circ was done. And finally, this is the IVUS runs where you can see the circ and the LCX carina, which has been very well. There is no strut across it because it is a single stent strategy, and you can see the luminal diameter is almost 13.25, which is very helpful. Now then there was a need of port, and this was also decided on IVUS, and you can see the apposition is very well. There was a little bit of job to be done over here, but definitely we were happy that we could leave this patient at that stage. Now this was the pre-results and the post-results that you see. Now finally going to ostial LMCA disease, this is a very important role of IVUS in ostial LMCA disease. For example, you see this is a typical ostial LMCA disease which needs this thing. Of course, there is a circ lesion. The ostial LMCA stenting pre and post, you can see from 5.44 it came to 15.24. And it was because we did a cutting, which can see some amount of calcium here, do a cutting balloon and finally complete the job. For true bifurcations, you have to see which angle is there and you have to size it and have to size your stents. Something which you all know, the eyebrow sign once you have an eyebrow sign, it indicates that possibly this artery will get closed. And there are two things which I'd like to highlight upon: what is a carinal shift and what is a plaque shift. This has to be identified upon IVUS because the strategy is different. If it is a plaque shift, then you have to use a large balloon. There will be more injury and there are more chances that the sideband stenting will occur. And this is a carinal shift, only use a small balloon, less injury, less chances of sideband stenting. So this is something new that you have to know while doing your IVUS, that whether you have caused a plaque shift in a single stent strategy or has got a carinal shift. Now let me take a DK crush where you can see that this was a double vessel disease. You can see the LAD diagonal, and here you can see that the LAD and the diagonal are all flowing well, and these images are almost comparable to the OCT. Just 2 minutes more. Finally, stent deformation can be known. Calcific lesions, as I told, this was a very calcific lesion, and you can see I had compared both the OCT and the IVUS, and you can see the cuts are very well visible also on the IVUS. So this demonstrates the use of it, and finally the well expanded stent. Instant restenosis, you can know the cause of instant restenosis, and you can know that whether there was neointimal atherosclerosis, use a cutting balloon and go ahead and stent it. So these are some examples which are stent failures. For example, this patient underwent an angioplasty at a peripheral center. There was no pre-dilatation, no post-dilatation, and within 35 days, the patient comes with another MI, and when we see this patient, the stent has already got thrombosed, and the reason of the thrombosis was there was some amount of intimal hyperplasia, there was a non-apo stent, and there was ring calcium. They should have worked much further and should have done the job. And the final IVUS evaluation, we can send optimally IVUS, optimally apposed stent. Finally, complications do occur, and this one of the very common complication is the guide catheter induced dissection, that is a subtotal RCA occlusion, and while just engaging the guiding, there is a total occlusion, complete heart block, and this happens that again quickly the wire is in the false passage. Now here you can see the proof of this thing, that is a true lumen and the false lumen, and the thing is that the STAR technique was used, and finally the results was good in the long run. So if you had to ask me that, also it detects all the stent related complications. For example, an incompletely crushed or deformed stent, if you form a small gap, if the floating struts, all can be detected on IVUS. So numerical precision is the very soul of science. So when you use beyond angiography, when you use IVUS, definitely IVUS will help you in knowing what you have done, and if you follow all these steps, you'll definitely have a good result. Thank you very much for the patient hearing. Thank you, sir.
So just wanted a clarification. I think it was a nice talk. You talked about how you aggressively correct molar position. Just wanted your clarification on, do we need to collect every molar position or only molar position with an under-expanded stent? Do we really need to collect a molar position in a well-expanded stent?
First of all, if it is an acute setting, there's no need to go on expanding, because flow will occur. Now, if it is a chronic setting, if it is more than 10% of the stent struts are not opposed, please dilate so that you get a good result. 3 or 4 struts not opposed is acceptable, but don't be very aggressive, because IVUS images are such that you feel to be over dilated. So there is a little bit of word of caution when you use an OCT versus an IVUS. And IVUS, you have to sometimes have a little bit imagine what you're doing, and never leave a malopose stent, never leave an unopposed stent, under expanded.
Thank you. Thank you very much.
For diagnosis of intramural hematoma and SCUD, do you prefer IVUS or OCT?
Intramural hematoma can very easily seen on IVUS also, but the strategy, what will it be? Now the extent of intramural hematoma can be very well seen on an OCT, you can see. But the problem is that in OCT, when you have to push more contrast, there's more further propagation of the intramural hematoma.
In a very big artery, OCT may misinterpret intramural hematoma as fat. That's a problem. Yeah.
Similarly in SCUD as well, like in OCT you have to push more contrast, it can cause increased dissection, and IVUS is not so sensitive to pick up the sometimes small SCUD dissection as well.
My experience with the 60 megahertz IVUS is that I'm happy with the 60. We used to use the 40 megahertz around 8 years back. Now we have shifted to the 60 megahertz. Definitely we see that the results are, we are more almost comparable to OCT. That's all.
Thank
But
you.
it needs time. It's just a learning curve. Let me
Yeah.
be very frank with you. I've been doing IVUS for the last 14 years, and I've really learned the hard way out. That's the whole thing.
Thank
And OCT for the last 8 years, it's easy to interpret. And the younger generation, they don't accept IVUS, I see. They're more happy with OCTs. That's it. Thank you, sir.
Yeah. Thank you. Thank you very much. Keith, the next talk.
Dr. Gupta, Dr. Ankush Gupta.
Ankush,
So I'm already here.
you are there.
As Dr. Sahoo told that, people are very happy seeing, OCT. Yes, it's very clear. You can see, coronary artery very well. But I strongly believe that both in present era, in selected cases, imaging should be used. Either you are using OCT or IVUS, because we have got evidence that it improves the outcome. So one of the major limitation when we think about OCT, that amount of extra contrast that may be required for doing, flushing of the artery to get images. So I'll be sharing with you our study that we did on how to, go about zero contrast OCT. So whenever so as we all know that right now we have got, OCT and IVUS has got class 2A recommendation for selected cases. And I strongly believe that in a year or so, where that imaging will be class 1 indication for, selected cases. So whenever we think about OCT, there is one thing that come to our mind is the extra amount of contrast that is required for flushing the artery for getting image acquisition. So these days efforts are being made to look for, contrast sparing media so that we can flush the artery without contrast and we can get good images. Low molecular weight dextran has been used. Dr. Rajesh has published also, and in low molecular weight dextran we saw that images are as good as that of contrast, but it has got its own limitation of availability, anaphylactoid reaction, nephrotoxicity. So it was 2018 when we were doing OCT. I think I was doing OCT of mid-LAD, and the routine is to give NTG before taking a run, and we saw that it is getting cleared. So that was the first case when we thought, let us try and do saline OCT. Let us try and see whether we are getting good images or not. So that is how it all started. And when we found that there was one paper in which preclinical animal studies have been done with the saline OCT, and that peripheral OCT was being done with the saline. So that is how we, hypothesized that let us do one study to see whether saline is feasible or not. So we did this SOCT PCI study, which was feasibility study just to look for whether is it possible to flush the coronary artery with hypernized saline and the kind of images we are getting. So this was a prospective study in which we enrolled 27 patients who are undergoing OCT guided PCI. All were injected with hypernized saline. It was hand injected. We use hand injection because we were not sure that how much volume of the hypernized saline is required, what will be the pressure. So we monitored ECG and hemodynamic changes that during pullback. So a total of 118 runs were taken, and they were analyzed by experienced investigators, and we categorized the OCT run into good runs, clinically usable run, and clinically not usable run. Good runs were those that were at par with that of contrast, in which you can see all the 3 layers of coronary artery more than 270 degree. Clinically usable run had a blood swirl in it, but you can see the proximal reference diameter, distal reference diameter. You can see the plaque morphology. Means that you can optimize your PCI using this kind of run. Clinically not usable run were those in which that didn't have any diagnostic information. You cannot use it for PCI optimization, and we combined this good run and clinically usable run into effective runs. So a total of 180 runs were analyzed. There were no hemodynamic changes. In fact, we observed that CKMB level after 12 hours, there was no increase in CKMB level. Transient ECG changes were there, that whenever we flush coronary artery for NTG or with the saline, we get transient ECG that were there. But there was no complication while injecting a saline for OCT run. Out of 180 runs, the good runs were 61%, clinically usable run were 27%, and the clinical not usable run were 11%. So to combine the clinically effective run were 88%. So this study showed us that when you use saline, that you can have a success rate of 88%. When we compared left and right coronary system had a tendency to have a better, more number of cases were getting good runs, but that was not, statistically, this difference was not statistically significant. Let me show you some images. So all these are saline images, saline OCT images. You can see all the 3 layers of the coronary artery. You can see TICFA, you can see fibrotic lesion, multiple layer of stents. One thing, whenever you do OCT with the saline, you will see these kind of, speckles. You can see dissection, calcified arc, calcified nodule. You can see, vasa vasorum also, cholesterol crystal also. So this is an example of, So this is an example of, clinically usable. This run has got a, blood swell, but you can see the distal reference diameter, you can see the plaque morphology, and you can see the proximal reference diameter. So this is the example that you have got a blood swell, but you can use this run for, PCI optimization. This is an example of, clinically, in fact, good run. This is a post PCI RCA. You can see very well. See, this is again a saline run. You can see everything that you can see with the contrast. So this was the study in which we use heparinase saline. This was the first human study that demonstrated that it is feasible to use heparinase saline for OCT image acquisition with a success rate of 88%, and there was no difference in the image quality between saline and contrast. OCT and all the image, all the coronary lesion close to histology that we can see with the contrast could be seen with the saline also. And in fact, we observed that if you have got a very tight lesion, yesterday that I think second case, those kind of lesions, we can get a better image with saline as compared to the contrast, because saline has got a low viscosity. In a tight lesion, you can, inject it. And we found that, that in a very tight lesion, saline may be slightly better than contrast in few cases. So this study concluded that saline is safe and effective flushing media for coronary OCT. And we published this study in Indian Heart Journal as an associative PCI study. But one question remained, that what is the impact of saline on measured vessel parameter? So there was one study that was done on rabbit aorta that showed us that whenever you image the artery with the saline, the measured vessel parameter are slightly smaller as compared to that of contrast. Then we did this study. Then we compared this saline with the radiocontrast, and we prospectively enrolled patients. The aim of this study was to compare saline and contrast as far as measured vessel parameters are concerned. So this was again a prospective study in which we enrolled 9 patients, 26 runs were analyzed, and all again the injection was manual. We used 20 ml Leorlock for the contrast injection and 30 ml Leorlock. In fact, we used BMV syringe, that 35 ml syringe for saline injection. The sequence of the injection was NTG, 100 microgram of NTG, contrast, NTG, saline. So we tried to keep our OCT catheter at the same location, and then first we gave the contrast injection, then we gave the saline injection. And around 80 to 20 ml of saline was required for the left coronary system, and 12 to 15 ml saline was required for the right coronary system. So this is how it looks like. That this is one of our study case that in which we did a head-to-head comparison between saline and contrast. So 13 pair of clinically usable OCT runs were analyzed. We compared minimal lumen diameter, distal reference diameter, and proximal reference diameter, as well as percentage area stenosis. So when we measured the anatomically, we measured the coronary artery, we use a number of anatomical points, because as we all know, whenever we take OCT run, first and second run will be different because there is with the contraction of heart, you will see the different length of the coronary artery. So we use a number of anatomical markers like side branch, macrophage, calcium, or dissection, so that we are measuring the coronary artery at same anatomical level. So, so we used a number of anatomical markers. This is an example of our study case. If you will see, this is the contrast run, this is the saline run. So can you see? we use even the angle of calcium, the diamond-shaped calcium. These are the comparison. This is the comparison how we did. We even use TICFA, thickness of the, TICFA so that we are measuring the coronary artery at the same level. So this is an example of left main to LED PCI head-to-head comparison between contrast and saline. So even whatever you can do with the contrast, even 3D reconstruction, side branch optimization, you could see both with the contrast as well as with the saline. This is another example. Can you see that we used all the net thickness of the fibrotic plaque so that we are measuring at the same. This is the contrast. The diameter here area was 2 and here it was 1.94, 1.97, 1.79, 1.65. So what I want to emphasize that we went ahead, we marked the coronary artery anatomically and we tried to measure all the parameters, MLD, minimal lumen diameter, distal and proximal at the same anatomical level. This is another example where we compared and measured the contrast and saline run. Everything that you can see with the contrast, it was visible with the saline. This is another example of left main to LED PCI and comparison was done between contrast and saline. So let me show you. So in another case, even can you see this was the recanalized thromboid dissection. We anatomically, we saw both at the same level. So we worked quite hard to measure the coronary artery at the same anatomical level. So it was not a core lab study. We did it independently. So let me show you the parameters. So the concern was whether what is the difference between saline and contrast measured parameter. As far as MLA was concerned, we found that in some cases the measured saline parameter, the measurement was slightly bigger than that of contrast, and the few measurement was slightly smaller than. So our concern was whether we are getting smaller measured vessel parameter as compared to the contrast that we saw in the animal study. It was not there. We thought, we strongly believe that our sequence of doing it, that NTG contrast, NTG saline must have contributed to it. This is the various proximal and distal reference diameter comparison between contrast and saline. When we compared it statistically, the difference was not, this is the difference between proximal distal reference area between contrast and saline. When we compared it statistically, the difference was not significant, number one. And when we saw each and every case for PCI optimization, again, the difference was not significant. When we did the planned Altman plotting to see whether saline and contrast are in good agreement for PCI optimization, yes, they were in good agreement. So we concluded that saline OCT is safe and feasible with a success rate of 88%. All lesion morphologies can be seen with saline OCT. Saline OCT does not significantly, affect the measured vessel parameter as far as PCI optimization is concerned. But yes, we know the limitation. The size of our sample size of our study was quite small, and these are my tips and tricks for doing saline OCT. Whenever you are starting saline OCT, start with RCA. For our lab, we use 20 ml Leolox syringe for RCA and contrast injection. For left system, we use BMV syringe saline for saline injection. And recently, we have started in a big, left system, and for measuring big left main while doing left main PCI, we are even using this, tower syringe also, 50 ml syringe. We have observed that it's not the pressure, it's largely the volume that is required. So whenever you are trying to do saline OCT, start with RCA, align your guide catheter with the artery that you are trying to image, always give manual injection, and use 30 ml of Leolox syringe for left and 20 ml can be used for the right. And always give pre-run NTG, because we have seen that it doesn't affect the measured vessel parameter. Take 75 mm run, because 75 mm run get complete in 2 seconds, 2.1 second. That is why, saline has got a low viscosity. You have to give slightly more pressure, you have to do more volume, and you can do it only in 2 seconds. So take 75 of run to start with. And the most important thing, even if you are, whether you are doing contrast OCT run or saline OCT run, the most important thing is keep your eye on the OCT console whenever you are injecting, because each artery is different, size is different, your area of interest is different. Sometimes you can get away with 6 ml of contrast, you can get away with 10 ml of saline. So whenever you are injecting, keep an eye on the OCT console so that you are not injecting too much. You can adjust your pressure as well as volume as far as both saline and contrast is concerned. So we published this head-to-head comparison with the saline and the contrast in CRM. So this is all about saline OCT.
Excellent presentation, Dr. Gupta. This was a very nice concept and great research.
Yeah.
Can I ask you the question about, the design that you used with nitro contrast, nitro saline?
एक सेकंड, अभी presentation out मत करना, sorry.
Does that give the saline dimensions somewhat of an advantage because you're giving nitro and contrast, which are both ways of dilators?
Yeah. So that is what I was sharing, that one of the letter to editor by Ziad Ali in JAG, he published his data that he showed us that with the saline, that he was getting smaller diameter, but they never published how they did it. So we thought that this sequence of NTG contrast, NTG saline must have made difference, because actually even now we are doing another study on the saline OCT with a large sample. We are observing that many a times we are getting higher measurement as compared to contrast, number one. Number two, even if the difference is there, that is not significant as far as PCI optimization is concerned. So before saline OCT, it's always advisable to give at least 100 microgram of NTG. So if you permit, I'll show you one case in 2 minutes.
Go ahead.
Can I share the slide?
Yeah.
Okay. So yesterday, sir showed us beautiful cases. So let me show you one case. So this patient, 65-year-old female, she came to us with the anterior wall MI, significantly diseased osteal LAD. So operator decided to nail the ostium. So he placed, I think, 3.5 15 stent, and this was he saw that the stent was underexpanded. So he did he pre-dilatation with the cutting balloon, and after cutting balloon he post-dilated the stent. And this is the post-dilatation. If you can observe, this was under expansion here. And he post-dilated with the appropriately sized balloon. This is what happened. So he was trying to nail the ostium. He placed the stent on the ostium. The stent was not adequately dilated near the ostium. He post-dilated it, and this was the result. So what's the opinion of the house? What needs to be done for it?
Actually, just show the LAO caudal view.
So
In this view, Ankush, if you see, the angle of circumflex is extremely acute, and in this case, like if I have to work, I will go from left main to LAD, and then provisional T if at all need be, and 99% you won't require it. I think what has been done is there is a plaque shift and probably dissection and hematoma which has been created at that place. I don't know.
So this is fantastic as far as your experience is concerned. So I'll show you how we interpreted the image and how image helped us. Any other opinion? So we thought that he was trying to nail the ostium. Then we thought, let us image it, let us see what happened. The concern was whether there is any dissection or what is there. So this was the, so he pre-dilated the lesion with the cutting balloon. Can you see this is the hematoma? So then he placed the stent from, operator placed the stent from left main to LAD. Can you appreciate this is the stent that has come across the LCX, and there is shift of hematoma. You are absolutely right. I'll show you, you'll see here the intramural hematoma. Can you see this? I'll show you in the next slide. So there was shift of hematoma. Can you see? So this was the hematoma. Now we are trying to nail the ostium. It was not dilated. We post-dilated it, and this is what happened. Can you see the hematoma behind that?
Yeah.
So what will you do now?
Now the mass has already been created. I like to wait and watch. If all is sealed, I will allow the hematoma to get absorbed if both the sides are sealed properly. If you go on working on it, there is a good chance that hematoma can progress proximally, and if it progresses proximally further, it can extend inside the left main, or sometimes, it can create a very major issue. Yeah.
Any other opinion?
I had the similar thought. In fact, I was just asking Dr. Samir that since the dissection is happening, hematoma is there and the stent has been already, it is not going to progress forward. Can we just leave it like that?
Yes, because if there is a good lumen area and hematoma is keeping there, it is a good idea to do the check angio next day or next to next day, and if the patient is stable, by and large, you can discharge keeping a close eye on the patient and allow the nature to do its work rather than intervening and aggressively intervening in these areas.
So what is the opinion of Professor Akasaka?
To the Dr. Patel, the dissection or hematoma never goes to the distal portion, and so if we have a chance to wait for a few minutes and a few hours, it will disappear. But it depends on the case, right? So
she was stable, but we were just worried about that angiographic appearance.
Yeah.
Then we did OCT.
Right.
Yeah.
So if you try to touch that portion, as he said, there are some risk of hematoma expand to the proximal site, and there may be a aortic
Absolutely.
hematoma.
There is a chance of dissecting aorta in this case. Supposing if this particular hematoma is in somewhere distal in proximal LAD or mid LAD, I will use a long stent and I will disperse the hematoma. Like if it is a 10 millimeter or 15 millimeter, I will use 28 or 32 stent to disperse it all around without any toothpaste effect. But this is a very, very vulnerable position. Abhiram, what is your opinion?
I agree. I think observing in the cath lab for a while and then maybe bring them back, like you say. Agree.
I will like to do repeat angio on the next or next to next day, and if the patient is stable, I will discharge the patient keeping a close eye.
And Rajesh sir, what is your opinion?
Other than having a progression to the aorta, there is a risk to an occlusion of the left circumflex as well. And this is the left main. Either you have to observe in the cath lab itself, it's not going to give you the time to take the patient back. Next day, in case there is occlusion on the left main, there is occlusion, it's going to be catastrophe. So it's a calculated decision. You have some under expansion of the ostial LAD stent. You can very well go ahead and put a stent from left mid to LAD as a crossover stress sting.
So fantastic. So I got one different opinion. So why I brought this case? First message, try in this kind of case, as Dr. Tejas Patel said, never try to nail the ostium, number one. Number two, use imaging appropriately. Now we know that there is shift of hematoma. So we analyzed this case for good amount 10 minutes. We saw each and every frame here. We found that there is hematoma in the left main, but that is not communicating with the lumen, number one. So either we are going left main to LAD, putting a double layer jacket here. So in our lab, imaging is almost 100%, and we strongly believe imaging. So at this point of time, we shifted the patient out. We labeled it as there is a hematoma in the distal left main. This is the area. Area is not significantly compromised. So then we took this patient after. So this is the hematoma that has been shifted. It can be seen in cross-section view. Then we did check angio after 3 months. Can you see?
Beautiful. This is gone.
So this is the how to use imaging. So this hematoma was there. We analyzed the pre-stenting imaging, hematoma was there, it got shifted while it was being post-dilated. So then we did OCT image also. I'll show you the OCT images. Can you see this? That hematoma that was there, that was reabsorbed, and that can be seen both in cross-sectional as well as in this view. So this is how we should use imaging, but as rightly said by Dr. Adesh, that if this hematoma ruptures, if this catastrophic left main occlusion, that can be life-threatening. But yes, we saw that hematoma, that lesion over that hematoma that was quite stable, thick fibrotic layer was there. So that is how I'll show you this view also. This is where we left 3 months back. This was a complete reabsorption of the hematoma, and in that angiographically also it got resolved.
So what was the MSA when the first time the stent was deployed?
Where? At
LAD, yeah, ostium, where it
that
was.
MSA was good, it was more than 8.
Then there was no need to touch it.
Yes.
First of all.
So
there was no need
so
to
that
touch.
that is what I
So
wanted to.
every time we are looking for, see what has happened with increasing use of imaging is, people have become very conscious about giving a very cosmetic result. And it is a good idea that if you have a MSA of 6 or more, even if it looks little under expanded, if you see a good this thing or white bar over there, I will leave it alone.
So we thought that this is the hematoma and this is the thick cap over it, and we knew that it's not communicating. And that, as you said, it got reabsorbed, and we got a decent angiographic.
So I would just add that in my practice, I deliberately leave a taper at the ostium to avoid this problem. So I would not say that never try to nail an ostium. There are anatomies where you can nail the ostium. Increasingly, we're very comfortable getting into the left main, but I still try to avoid it. I come from the days when we didn't stent left main, so it's sort of intrinsic in me, but I do it by design. I sort of taper it back to the true ostium and leave a slight stenosis in a large vessel. You can do that.
Yeah.
Yes.
So one simple question, between the acute post-stent OCT and the 3-month, it almost looks like the ostium was dilated again. The stent at the very ostium looks bigger, even though it's not a self-expanding stent. How do you explain that?
So I think it's a reabsorption of hematoma that has given way. I'm not sure. This is the case that I wanted.
Yeah. Do you see what I'm saying? I mean, if you look at the 3 OCTs in a row, if you go to that slide,
let us see.
I
think that maybe frame size may be different.
But it clearly looks like the true ostium of the LAD,
that has expanded.
The stent has expanded, whereas the balloon expandable stent, so should not enlarge.
But I think MSs are same. It is 9.19 here, 9.19 here. Let us see what was there. 9.33, almost same.
Yeah, although I'm not understanding the behavior of the metal, why it would get expanded.
So I noticed it just now, but again the difference is not great, 9.19 and 9.33. But again, this is how we should use imaging in our practice, I think.
What is the best way to treat once again such patient occur? How do we approach? How we treat once again such patient occur? How we treat this lesion? This is we have started the stent from the ostia. Next time we should yeah.
See, that is why I asked for the LAO caudal view. An LAO caudal view has a circumflex which has such an acute angle. Circ will never occlude. With a clean circ and this angle, you straight away do LMCA to LAD, and that's it. No.
If you are putting a stent from left main to LAD, nothing will
Only
happen.
if there is hematoma and hanging dissection, you are in trouble. There is no hanging dissection there. Thank you, Ankush. This was a great case.
Thank you, sir.
Yeah, Kiran.
Sir, is there any relation of development of IMH with use of cutting or scoring balloon?
You are creating a big dissection. So whenever there is a big medial dissection, there will be some hematoma behind the dissection by and large.
Dr. Selvamani.
Yeah, good morning, everybody. I thank Dr. Tejas Patel for calling us here, from whom we have learned radial intervention probably 20 years back. I learned from him and a lot of other interventions, and it's really a privilege for me being here. So today I have been asked to talk on acute coronary syndromes and OCT, and it's been an excellent discussion since morning. Can you help me with the laser pointer?
Give him a laser pointer, please.
Yeah. It's there. Okay, fine. So what I will do is, and basically he has asked me to talk on case-based scenario. We will see why should you do an OCT. Basically, can you see always there is a question, should you do an OCT in acute coronary syndrome? See, there is a guideline from the ESC which says that almost 50% of the time probably you may not need it, where the culprit is very clear. And there are another 50% where the lesion is not very tight, and then there is some ambiguity. So where definitely imaging, especially OCT, gives you an idea. But basically we will see the cases and then finally we'll conclude what it is. When you look at the lesion classification of acute coronary syndrome, it's basically plaque rupture or calcific nodule or erosion, and then scared and recanalized thrombus. And these are all very rare conditions that we have. But not only knowing the reason, but today our treatment also is decided on the reason why you get an acute coronary syndrome. We are all familiar that erosions, many patients can be managed medically. And of course for calcified nodule, we need a different approach. And of course plaque rupture, there is always a controversy which we will discuss. So just to complete, Sahoo showed you a ruptured plaque in acute coronary syndrome in IVUS. And IVUS, it's always difficult to make out so clearly about the ruptured plaque. So this patient had an inferior wall MI thrombolized outside, and is having around 60 to 70% lesion in the circumflex. And look at the OCT, it's very clear that you can make out the plaque. So this is the ruptured plaque that you had. And then this is the angiogram that you are having there, around 70% lesion. Not only plaque, you look at the lumen area is also reduced in this patient. So lumen is also reduced and MLA is only 1.7, and there is a ruptured plaque there, and which you can clearly see that there is a ruptured plaque which is communicating with the lumen. And other signs of inflammation like macrophages, cholesterol, microvessels are all seen in this patient. So there is no doubt you go ahead and put a stent there. Stent it and then come out, and post stent of course you assess. I will not go into a detail of that. And there is another case now. Look at this. This is an inferior wall MI, again thrombolized, and angiogram looks like this. So do you really want to stent this patient or just put him on medical management? What is it? Is it an erosion or is it just a thrombus? When you look at the OCT here, there is something like a rupture here, and there are some content inside the plaque, and then of course the lumen is not so bad here. So here comes the controversy. Like probably many people suggest if the lumen is good, you can just put him on medical management, or if there is a rupture itself, you should go and stent it. Especially there is some material inside the plaque or the ruptured plaque, it's better to go and stent this type of patients. And of course this patient was stented and went away like that. And now comes the very important discussion that most of us will be coming across in day-to-day practice. So here is some 40 to 45 years old MI patient, anterior wall MI. This is a natural angio, common angio you see after an anterior wall MI here. So probably what are you going to do now? You go wire it and then probably do a thrombosection or ballooning. So whatever you feel, you do it. And you look at the angiogram after you do a thrombosection there. So once you do like this, so what is the common phenomenon? For example, the next reflex, what we do is, probably there is a narrow lumen there, you go and stent this patient. So, but in such cases, like where there is a good flow and then you are really not sure what is happening, look at the next angiogram, you look at the OCT finding in this patient. And have a look at this angio also. It's not a very clear atherosclerotic narrowing that what we are seeing there. So there is some doubt. So I did a OCT there. And you look at this OCT image, there is its lumen is narrowed, yes, that is why the angio is looking like this. But whenever you get a narrowed lumen also, you should see why this lumen is narrowed. Is it an atherosclerotic plaque or is it a thrombus? What is it sitting there? Is it a rupture there? You will have to see that. So in this patient, you just have a look, it's all full of thrombus there. And then you can look at there is plenty of thrombus and I don't see much of atherosclerosis there. And always there is a problem saying that when there is so much of thrombus, how do you make out a rupture there? You can't make out. That is what my friends ask. So for that there is a technique. You go into the longitudinal view in the OCT and at the thrombus area you try to concentrate and see properly. There is no intimal break at all in this. You just go through the entire area. You can rotate and see in all the quadrants. You don't see any rupture in the intima at all. So, but if there is a rupture, which I will show you, probably I have showed you also, there will be a crater-like thing which is going beyond and there is a break in the intima. So this patient is clear, full of thrombus, there is no rupture, and that lumen narrowing is because of the thrombus, not because of the atherosclerosis. So what I did is I left him on medical management, and 2 weeks later, so this is the angiogram, you see here, 2 weeks later, angio is completely normal, the thrombus is dissolved. He was on double antiplatelet and one vitamin K antagonist, and then he goes, and this is the OCT after 2 weeks, which shows that there is a minimal plaque and the lumen is very good, and nothing happened for him. Probably he can be left with medical management, avoiding a stent in the proximal LAD. And this is also another common scenario in an anterior wall MI. So he had an anterior wall MI like this, so you do a thrombosection again. And when you do an angio, many times you will get a lesion, like it's a very diffuse disease here. And probably it's an associated spasm. And then you don't know where to put a stent. Should I put it in the proximal segment or distal? In such case, you do an OCT. It clearly tells you how much is the plaque burden here, where is the landing zone, and what is the distal vessel diameter, and what is the reason he had an MI. It's a plaque rupture, and distal vessel sizes, and then you get a proximal vessel size also. And then you can clearly decide to look into because if in a diffuse disease, it's very difficult to find a landing zone. You'll find a landing zone where the plaque burden is less than 50% and try to place it there. And this is a post-stenting OCT that you are seeing, where it does not reveal any dissection. And one more advantage is, whenever there is a doubt, you tend to take a lot of injections, giving a lot of contrast, which can be avoided in such patient. And many times in an acute coronary syndrome, you just get something protruding here, what we call it as plaque prolapse. And then if it is more and TIMI3 flow is not achieved, probably you'll have to treat it, otherwise you can just leave it like that. And basically, we get a good expansion in such cases also. And this is one of our routine, normal way you treat an acute MI in your routine practice. Now look at this angiogram. This patient also has an acute coronary syndrome, having an ACS, and there is an AZ angiogram there. So what do you think it is? It's very impractical or very difficult to make out what is there in this angiogram. Probably many times you may just leave it on medical management, or you don't know what it is, or you go and stent it. So when you do an imaging, you see here, this is what we call it as recanalized thrombus or lotus root appearance. Many times this is what you get in such patients. And there are certain things that you should know in this. But although it is a recanalized thrombus, many times it behaves like a CTO, because when you put a ordinary wire, you may not cross it very easily. Probably you need a harder wire or some balloon support to cross it. And many times we deal it like a CTO, take a stiffer wire and cross it and stent it. And this is also another case where it looks similar. This is, and again, an aziness in the LAD there. And this also is a recanalized thrombus. It all depends on the number of lumen that it has created. And many times you can take a decision whether to treat it or not also. Based on OCT, you can measure the effective lumen area. You can measure the different lumen area there, take a effective area and take a decision whether to stent it or not. But my experience in most of the cases which are like this, if you do a FFR, it is positive. So all these cases we generally stent, and then you can look at the effective areas and go ahead and do your way there. And coming to SCAD, it is basically like, I would like to give a definition because most of us might have forgotten or don't remember it. It's a non-traumatic separation of the arterial wall. And there are three types there, type 1, type 2, type 3. And very important is this type of thing, most of us would have stented, we would have come across. Only if you have not done an imaging, you cannot diagnose it because it just resembles atherosclerosis. And sometimes like this, in a diffuse disease, you have a patient with ACS, especially younger patients and ladies. If it is like this, better do an imaging. And what you should be cautious is, look at this angiogram. This is a lady who is 42 to 45 years old, ACS, and there is something, a diffuse narrowing in the LAD here. And then such patients, what you do is look at the OCT. So this is another view that we are seeing here. Should we go and stent this, put a cutting balloon or scoring balloon, and then dilate it and put a stent? What should we do for such cases? We first do an imaging. And once you do this imaging, so OCT clearly it is showing that there is nothing inside the intima or a lumen, there is nothing. But there is an hematoma-like thing. That is what you should see is there is a separation between the media and the intima. In between these two layers, there is something probably a blood there, what many of you call it as hematoma, or we call it as a separation between the intima and the media, which we call it as, which has occurred spontaneously without any intervention, probably, or very area provocation. Probably it's a spontaneous coronary artery dissection, but the intima is intact. There is no contact between the intima. And you can assess it in the longitudinal view also. And this point is something like a vasovasorum. And many times you should look for the vasovasorums also in a SCAD, I think, because the main pathology behind this might be, so it's not moving slowly. The main pathology is it could be inside out like this in case, which I showed that there is no tear in the intima and probably it's only in the media where it is happening, or it can get a cut from the intima and go into the media. So basically these micro vessels like vasovasorums can rupture, and then what it can cause is it causes an hematoma there and separation, and these patients tend to have this spontaneous coronary artery dissection. This is another case of SCAD where there is an intimal involvement. You see, there is something like a thrombus in the angiogram, but when you do an OCT, it's only thrombus, and when you see that, there is a definite break in the intima from where it has gone into the media, and there is involvement of the intima as well as the media. And one thing what you should remember is, many people confuse between a recanalized thrombus and a SCAD is, in recanalized thrombus, it is limited to the intima. It doesn't go to the media. But in spontaneous coronary artery, there is a definite involvement of the media. That is, it goes behind the intima and that is involved there. So, and coming to the next point there, look at this, an angio anterior wall MI, an angio like this, you do imaging, and this is what you see here. It is a calcific nodule that you are seeing there, which is protruding there. Many times, it is a must that probably you give some time to interpret your images. And today's problem is, many times in our hurry, busy practice or busy procedures, we tend not to interpret the images properly. So the same thing happened with this case also. Although I had done a OCT, we did not concentrate much on the calcific nodule which was present. And then it was balloon dilated and stented there. So once you stent there, what happens, you see there is a clear malapposition, And then, of course, we have expanded the stent to the maximum. And you need something extra. But one more thing is, if you have something like this, be careful. Don't try to chase this nodule, because the opposite to the nodule, it is a normal segment. If you chase it, you can have a perforation opposite to that. So probably you can just leave it and accept it. Angiographically, you cannot make out this. Malapposition, you cannot make out. Everything looks good here, but in OCT, it clearly shows there's a nodule which has not been treated. In an acute MI, this is probably I'll show you. Probably I will exceed 1 or 2 minutes, so you'll have to bear with me. And look at this nodule. See, there are different types of nodule. One is, this is a classical eruptive nodule. You call it as an eruptive nodule. You just concentrate here. There is the break in the intima. That is, there is no cap for this calcific nodule. And for this also, this is very common in acute coronary syndrome. And this many times, eruptive nodules can get compressed easily. And you cannot equate all nodules as a same thing. There are some nodules, whatever you do, in spite of IVL, rota, orbital, it doesn't get cured there. It is left there. But only thing, be cautious about it for the stent expansion and malapposition. So this patient, this is an eruptive nodule, was stented. And again here, you see that post-procedure, there is an area of malapposition in the stent there, where we couldn't oppose the stent, whatever you do here. So when you just look into this image of this patient, what it is it is a calcific nodule. It's eruptive because there is a break in the intima here. And of course, rota also was done for this patient. In spite of that, there was a significant malapposition, and this nodule is still protruding. So this can occur. And two controversial cases I would like to discuss with you people here. See, this patient had an inferior wall MI, probably non-ST elevation MI, inferior wall, for which he was stented in the RCA. So now he has a lesion like this. See, because we have been concentrating on culprit vessel all this time now. Now you look at a lesion which is a non-culprit vessel. In an acute, some ACS in the inferior, an LAD lesion looks like this. So most of us, what will you do there? But probably seniors will say that I will just leave this for medical management. Or probably other trials say that I will do a physiology there, and I'll take a non-culprit physiology and assess. So beyond that, what is it? See, actually FFR was done. FFR, we couldn't complete the FFR because he had some bradycardia, but still FFR was negative. And then RFR also was negative in this patient. And then beyond this, should we stop here or do something else is always a question in acute coronary syndrome, especially treating a non-culprit lesions. And look what generally what I thought is, okay, anyhow I have an OCT, let me do an OCT. So OCT was done for this patient here. And look at the OCT finding. And OCT is showing so many things, like there is a narrow lumen, that is MLA is only 1.8 there. And there is, I'll show you TICVAs, macrophages, lymphocytes, all signs of inflammations are present here. So this shows macrophages, and there is a healed plaque which has been there, and it's a young fellow, probably around 40 years now, 42 years, and this is what is your finding. And it's all lipid here, predominant lot of lipid there with signs of inflammation. So do you want to treat this or just leave it on medical management is always a controversy. But anyhow, there is a trial called Forza trial where they compared FFR's guidance and OCT guidance. They did PCI. They had certain criteria. When the MLA was less than probably 2.5 with signs of inflammation, or if the plaque burden was more, even if the FFR was when it was less, they went ahead and stented. And if the FFR was negative, they put them on medical management if these findings were not there. So this patient clearly has an area that is an MLA between less than 2.5 and signs of inflammation was present. So based on this, when the follow-up, what they showed is, there is a great difference when you treat it with OCT and FFR guidance. But based on this, probably a long time back, this is almost, I have done it some 3-4 years back, done an angioplasty stenting for this patient, and then achieved an excellent result. See, to start with, the MLA was only 1.8, and then we made it to 6, and we have a follow-up. This can always be discussed. People tend to differ. And this is the last case which I will tell you. And this patient had and something acute coronary syndrome in the inferior wall. Angio was done on 28th, and then later on he comes on 2nd for further angioplasty and evaluation. The same patient, he had some ACS some 10 years back. Angiogram was done, and we did not see that angiogram at that time, but this was done on an 18th, and probably some 1 week later he comes for the procedure. So this is what is the lesion. So should we treat this lesion is always a question, but anyhow RFR was negative for that patient. And we did an OCT there. Look at the OCT, what it is showing is, it is a significantly diseased area, and then there are so many findings that you are seeing. What you are seeing is a ruptured plaque, and there is a ruptured plaque here. And you look at the lumen area MLA is 3 there. The minimal lumen area at this area is 3. So with this finding, so what to do now? You can look at the OCT here. It shows a clear ruptured plaque there, but a MLA is 3. When you look inside the plaque, there is nothing. It's all an empty ruptured plaque. And these are all probably healed plaques or intraplaque hemorrhages, you can call anyway. But I believe probably these are all healed plaques, but many people call it as intraplaque hemorrhages also. But looking at this, should we treat it or not? But I did not stent this patient because he had a very good lumen, and then there was an empty plaque, which is probably an old one, so I just left it like this for medical management. So I think with this we will go for discussion. Thank you very much for listening.
I think we have a time for only one question because it was a beautiful talk, and it was quite educative.
I think in SCUD there are 2 group of patients. One is a stable patient TIMI3 flow. You leave this medical management. Second group of patient who has SCUD and who has impaired TIMI flow and then symptomatic EC changes. Will you do the cutting balloon to dissect intima and then drain
so
the
you're
intima,
discussing about the management of spontaneous coronary artery disease.
Yeah, especially the second group of patients who are hemodynamically significantly impaired.
Yeah, see, if there is an hemodynamic compromise, for example, LAD is down or the lesion is in the left main, patient's hypotensive and is unstable, you should go ahead and treat. So your treatment depends. Like for example, if there is an area where you think there is a big hematoma and you have an adequate sized cutting balloon, you can try to cut the intima, allow the hematoma to come down. So when that hematoma comes down, if there is a TIMI3 flow, if the patient is stable, you can still stop there. But in spite of that, if you are unable to do, or the hematoma is expanding, as Tejas sir was saying, you can take a long stent and cover the entire lesion. Don't over dilate. So just come out of the acute crisis and then decide.
I think last comment from Abhiram, because I think Mayo Clinic has done a good amount of work on SCAD and its management.
Yeah, I can't take the credit. Dr. Gulati has done most of the work there, but we are one of the referral centers. I think you've covered everything. The main message is obviously conservative management, but when patients are ischemic, you do treat with the techniques you've said. We don't have a lot of experience with angiosculpt and cutting balloons for this purpose. I know it's been described. I'm not sure how often, if it's effective or not. Does anybody here have a lot of experience with using those devices? No. So it's anecdotal. I think that's.
Thank you very much.
Thank you, sir.
Dr. Akasaka.
Stent failure is actually OCT imaging, and stent failure is a very, very hot subject. And I think Dr. Akasaka has done a good amount of original work. So,
Thank you.
Yeah, please.
Thank you, Dr. Patel, for kind invitation, right? And this is my disclosure. As you may know, already 5 years ago, there are recommendations of the optimization for imaging, and also when you identify the stent-related complication, imaging is recommended as class 2A, as you may know. This is the one case with a STEMI. You can identify the total occlusion, and then we did an thrombus aspiration, put the EES as shown in the right-hand side. And soon after, we just get a little bit, yes, TME2 flow, but stent condition is okay with lots of thrombus protrusion, as you can see here. But we cannot control the thrombus at the acute phase. 1.5 strata protrude to the CX orifice, but enough lumen area, we leave it alone, right? And this is a still frame, and there are lots of thrombus protrusion. But 13 days after the patient had a chest pain and ST elevation, again, we did an OCT after thrombus aspiration. There are much more thrombus you can identify. Right, so we speculate this might be the poor metabolizer of clopidogrel. Then we did an additional bare metal, we avoid to put the additional DES, to put a bare metal stent, and then we change the drug from clopidogrel to the prasugrel. And finally, we check the genotype, right? To status and start with the poor metabolizer. We cannot control this, but it is very important to confirm we did the best way to treat the lesion, right? And then if it is speculated, you have to change the antiplatelet therapy. And 6 months later, still there are some abnormalities. Yes, angiographically good, and OCT demonstrate the well opposed and some neo-intima proliferation, right? So, but we are still afraid some evagination and also the protrusion of with some tissue proliferation. We still continue the prasugrel at least 1 year, right? Already there are report about the risk of stent thrombosis. We cannot control the patient condition and also the stent thrombogenicity. Yes, company try to change this condition, but it is important we try to check our procedure-related factors, right, by imaging, and try to avoid the under expansion and dissection, and also the tissue protrusion, but this protrusion, it might be very difficult, and also we check the antithrombotic therapy if you did a very wonderful procedure, right? And this is another case. 7 years after the patient stopped the DAPT because of the surgery. After stop the DAPT, the patient had the ACS, and then we check the OCT after thrombus aspiration. You can identify lots of evagination. This is a hypersensitive reaction, right? We already checked 9 months after putting a stent. At that time already we have some information of the evagination, but this patient may have a hypersensitive reaction to the polymer. Therefore, we continued the DAPT for a long time, but based on the surgery, we stopped. And then this is 9 months after ES implantation at the time of ACS. There are lots of hypersensitive reaction you can identify, right? So it is very important to continue the DAPT if the patient are poor metabolizer or hypersensitive reaction, right? And this is, yes, neo-intima proliferation. We had done ACS in case with bare metal stent for a long time, and you can identify thin cap fibroadenoma and rupture and thrombus here. And also this is another case. You can identify thin cap fibroadenoma and also the disruption at the ACS site, right? There are many causes of stent thrombosis. Mainly, you try to avoid the stent under expansion. Here is a stent under expansion, and our position also some of the cause of the thrombus and significant plaque at the edge, especially if it is lipidic, you have to avoid. And also the edge dissection or evagination or lipid-rich neoatherosclerosis may cause the stent thrombosis. Yes. And this is a summary of the stent thrombosis classification depending on the time of the event, acute and subacute, late and very late. And in uncovered strat is very common at the acute and subacute phase, and also neoatherosclerosis and stenosis is very common in the very late and late. And this is another case of ACS. We put a stent in the distal portion across the distal RCA AV branch, and also put another stent in the proximal site. So therefore, stent in the distal portion and also the proximal portion. But you pay attention to the guiding catheter. During pullback, guiding catheter deep engage. This is a problem, right? Just after, yes, it was good, but something different. Then the operator did the IVUS. You can identify double layer, and also no stent can be identified. That is the longitudinal deformity by the guiding catheter. It is very important to check the imaging after putting a stent, because by angio we cannot identify any abnormality, right? And also OCT gives us a much more detail, right? This is a double strat and absence of the strat at the opposite side of this strat, and also you can identify the incomplete apposition in the proximal site. And this is a case of, yes, a chronic stable angina stent implanted in the mid-LAD, right? And this stenosis, it doesn't work right. Right, yes. After putting a stent, the operator tried to pull back, but the operator feel some resistance. But it is very important after dilatation, pushing in the balloon a little bit distal, and then disengage the guiding catheter and then pull back. It is very safe, but this operator just pulling back with very resistance, right? After yes, pull back the balloon, you can identify. This is just post putting a stent. It's a very good condition, but after resistance, when they pull back the stent, there are yes, some absence of strat, and double layer can be identified. So not only a proximal side, but also the distal side may have the shortening of the stent. That is the one of the mechanism of the stent deformity, right? So OCT gives you much more clear image. Double layer of the stent strat can be identified here and here, right? And there are some data showing the shortening of the stent, also the elongation of the stent. So do not do it so aggressively after putting a stent, right? Or also when you go into pass the imaging device to after stenting, it is very important to check the resistance, right? Otherwise, you can make some deformity. This is another case of a chronic coronary syndrome, right? You can identify some instantly stenosis, right? And IVUS shows lots of tissue within a stent, and OCT gives you much more clearly the type of the tissue, right? As shown in this case, right? So the distal site, a homogeneous pattern, proximal site layered pattern, and some instant strat halo or evagination, right? So this is a mixed type of the instant stenosis. Especially this type is at the edge of the stent, right? Therefore, we did yes, paclitaxel coated ballooning finally, and then get a good result. And this is an OCT after paclitaxel, drug-coated balloon treatment, right? So you can identify the paclitaxel, drug with a high density signal, yes. And Dr. Patel already explained you yesterday. We divided in 4 different, basically 3 different type of tissue characterization by OCT. The homogeneous pattern, there are 2 types with a high backscatter, without a backscatter, right? And this is a proteoglycan-rich tissue. It's quite soft. Just ballooning, this tissue will disappear. And the homogeneous type, and also the layered type. It's an organization of the thrombus, yes. There are clear comparison between this type of OCT and histology, but anyway, this is a little bit busy slide, but based on this slide, I would like to say homogeneous high backscatter neo-intima drug-coated balloon is very effective. Otherwise, there are no significant difference between the simple balloon or a scoring balloon with a drug-coated balloon. So drug-coated balloon is very expensive, therefore you can save the cost in a case without the high backscatter signal-rich neo-intima, right? So this is a mixed type. Distal portion is signal-rich homogeneous, and this is a layered pattern. Proximal edge, still some tissue proliferation. At that time, we try to do the scoring balloon, and the result is very wonderful. Therefore, we leave it alone without any drug-coated balloon. And this is an stent fracture, right? At the time of ACS implantation, the stent is okay, but after 1 year follow-up, we can identify the fracture here, and by imaging, you can identify absence of strut at the site of the fracture, and proximal distal you can identify the stent by imaging. And also this is also yesterday, Dr. Patel showed you at the site of the fracture, the tissue proliferation is greater than the other portion. Therefore, if you identify no strut at the site, and then if it is tissue proliferation, that means a stent fracture. I'm not sure it is useful to put an additional stent here, but because there are some hinge motion at the site of the fracture, therefore additional stent makes a new fracture. So if it is okay by imaging, you can leave it alone, right? This is an this stenosis. IVUS demonstrated tissue proliferation at the site of the region, and OCT gives you a very wonderful image of what the type of the tissue as shown in this slide. So I think the diagnosis of the tissue proliferation by IVUS and OCT you can identify, but the type of tissue, OCT is much more clearer. Granular pattern can be identified, and after cutting balloon, you can identify the very good result and leave it alone. And this is a long-term follow-up. After putting bare metal stent, you can identify the calcium, superficial calcium, circular calcium here, and also the very eccentric calcium. So it is important to identify what the tissue are there, right? Otherwise, without imaging, we cannot identify the calcium, such a calcium within a stent tissue, right? And the cause of in-stent-lead stenosis is very similar to the subacute or acute thrombosis. Under-expansion is the main cause of the stent-lead stenosis, and plaque is another cause. If it is the big, more than 50% plaque and lipidic, you may have an H-lead stenosis very often, and dissection or flap maybe another cause you may speculate that this is how to treat the incidentally stenosis. It looks like a very complex, but it is important to use IVUS or OCT to identify the mechanism of incidentally stenosis. If you identify the stent under expansion, try to do the dilate using a higher pressure, bigger balloon, non-compliant balloon. But recently, if there are a calcium outside the stent, you can use IVL to make a fracture, and then you can dilate. So IVL is sometimes very useful in a case with an under expansion. And also, if incidentally stenosis is homogeneous, I already demonstrated a drug-coated balloon is very effective, but otherwise, they always recommend that DES, additional DES. And also, if you can identify the calcium within a neointima tissue, laser ablation or IVL might be useful to put additional stent before, right? So this is the data between the comparison early and late stenosis, and the late incident stenosis, lipid laden rich and neointima proliferation is very often can be seen, right? And because neointima proliferation is very rapid in DES, as you may know, compared with bare metal stent, this is more than 1 year follow-up, the problem of the incidentally stenosis. As shown in this slide, very late stent events occurred within 1 and 5 years, more than 1 year after PCI at the rate of about 2% per year with all type of stent. Therefore, I'm not sure the new approach are required to improve the long-term outcome. And this is a summary of the prevalence of TLR in case with acute coronary syndrome or a chronic coronary syndrome during early, late, and very late stage. Yes, and stent age pattern, they compared and the non-focal pattern, right? So the proportion of ACS or CCS increased substantially from early to very late TLR regions, and both stent age and non-focal pattern were higher in very late TLR compared with that's in early and late TLR. Although the stent age pattern tend to be more prevalent in CCS than the ACS region during early and late period, it was more frequent observed in ACS than CCS region during the very late period. Right, this is a summary of the incidentally stenosis mechanism and how to treat. As I already demonstrated, even in this area, the cause is very similar: anatomical factor, clinical factor, and stent-related procedure factor. We can only control the procedure factors if it is very important. The IVUS and the OCT, you can identify the mechanism, and under expansion is very easy to treat by imaging-based treatment. And then, finally, I would like to emphasize the crossover, the side branch. Long-term follow-up, this stent demonstrates the tissue proliferation at the orifice of the side branch. This is actually the problem, right? Early stage, it is okay, just cross over the CX orifice from left main to LAD. It is okay, but long-term follow-up, this may occur. And in this case, there are 3 orifices. Which orifice do you try to select to treat this region? It is the problem. If you select the proximal site, this area goes up to the main vessel of the LAD. At that time, you may have another problem. And if you try to do the kissing balloon, we do not have any good results to speculate, but still there are metal carina there. So if possible, it might be better to select this cell at the time of the crossover and then do the kissing balloon. If you can succeed to these cells attached to the proximal site of the side branch, you may have a big area, Right. So we do not have an, data at the moment, but it is very important, research work how to treat this condition. So this is my take-home message. Poor metabolizer of the antibiotic therapy might be the one of the mechanism of acute or acute DES complication, but type of stent or polymer and technical issue might also related to the stent thrombosis. We cannot control this. But under expansion, each dissection, huge malposition may lead acute or subacute stent thrombosis, and later acquired incomplete stent apposition, neoatherosclerosis, and covered strut with evagination could be the mechanism of late and very late stent thrombosis. Intravascular imaging could be useful to know the cause, and accelerated neoatherosclerosis is thought to be a cause of early instant stenosis in DES, and disruption of TICFA following slowly progressive neoatherosclerosis might be the mechanism of very late stent thrombosis. And after bare metal stent and intravascular imaging might be useful to know the cause of them and to decide the treatment. OCT assessment of neointima tissue characterization might be useful to decide the treatment strategy and to predict the recurrence of instant stenosis and target lesion revascularization. Thank you very much for your kind attention.
Thank you, Dr. Akasaka. I think it is still, a subject where we don't have the real treatment available, and we are just trying to improve the lumen in this area. But yeah, it was a wonderful presentation. Thank you.
Thank you.
Dr. Akasaka, you mentioned a couple of times that the edge type of restenosis is rich in lipid pool. What do you think is the mechanism? Is it natural, sort of adjacent plaque growing into the stent because it's very inflammatory and active, or is it something about the edge causing irritation in the vessel, causing the lipid?
I'm not sure. We just compared the lipid and fibrous and fibrocalcific and normal, and compared among these type of edge. There are actually the difference. Lipid-rich may have lots of edge proliferation and restenosis. Mechanism might be there are some stimulation to the plaque by the stent, right? It may cause some progression of the atherosclerosis at the site of the lipid-rich portion. I'm not sure in detail, but yeah.
Well, I have a second question about the side branches and the tissue growth that occurs when you cross over a side branch. I routinely balloon across at the time of implantation just to open the tines a little bit to avoid this. Do you think that's a good idea, and then finish with a final inflation in the main vessel?
Yes, I think, but it depends on the type of the crossover. In our experience, if there are link at the center of the side branch opening does not always act very well. Sometimes make an deformity of the main vessel cell condition, and also still there are metal at the side branch. Therefore, if there are link free, you can try to select that cell to make a bigger side branch orifice at the time of the intervention. It might be very good, but we have we do not have any long-term data. Therefore, we are now trying to do such research work.
Yeah, thank you. Actually, link-free or link-connecting carina is not in our hand. Only proximal distal crossing is in our hand. Yeah, so it is anybody's question. And sometimes you see, proximal, middle, and distal, three. In that case, you consider middle as proximal or middle as distal. You see 3 lumen in the side branch.
Distal might be the ideal if you try to cross over, but if
distal is very small, middle is very big, and there is a proximal, what will you do?
Yes, use the double lumen catheter, right? Yes, because Crusado, have the distal, yes.
Usually for your question, sir, when there is as 3 lumens, you do a 3D reconstruction. If it's in a remote cell, for example, you will have the third one will be a small cell, although it is distal, probably that's not the ideal cell. Probably, usually if it's somewhere eccentric, distal also is not good. Probably you can come back to the middle and do. You see it on 3D reconstruction and do. That is what we have been doing.
But like 125 odd left main bifurcation, OCT evaluation, in only 20 cases we have tried proximal distal, and then we are blindly, doing it and observing those patients, almost 1 year median follow-up. We are good at this point of time. We will be writing a descriptive paper on it. Yeah.
See, most of the time, if it's a single stent strategy, if you do an adequate pot, there are no connectors across the side branch.
No,
that is what we have seen.
I don't think so. We cannot control the link position, right?
Yeah,
it's by chance.
That's right, yeah.
If there are 3 links, there are a lot of chance to have a link at the side branch.
No, in spite of adequate pot, if you are seeing a connector, probably I think you should do a distal cross and do a balloon.
Yeah.
Especially in the left.
But I agree, yes, OCT gives us a lot of information of the link condition and the wire position.
That's right.
If there are link free and wire is proximal site, how to confirm to the wire is distal portion? You try to use the Crusader, and then Crusader goes in the side branch and then pull back and try to use the wire to select the distal portion, and if you succeed to select the distal portion, Crusader never goes. But if the wire is the same cell, Crusader goes in the CX, you can control the selection of the cell by using double lumen catheter as a Crusader, right?
Yeah, it's a great understanding. Thank you. So the next speaker, I think Rajesh.
Dr. Vijay Varghese.
Yeah.
Good morning, everyone. Thanks, Dr. Patel, for the invitation. My topic of the talk is role of OCT in calcium management. As you all know about, the PCI of heavily calcified lesion is technically challenging because there is a difficulty in delivering various devices, needs adequate guide catheter backup support. There is a need to have adequate bed preparation prior to put a stent across, and which do require more frequent use of NC balloon, scoring balloon, and various ablative therapy. There is also a need for the high pressure balloon dilatation, which may lead into drug-eluting stent adverse event, which includes say strut fracture, and otherwise also there are certain complications like dissection, balloon rupture, and perforation. Those with a calcified lesion do have a more maze at the long term of follow-up. If the lesion is not well prepared, the high frequency of PCI complication like restenosis and target lesion revascularization, and as I already mentioned about the inadequate stent expansion, apposition, and polymer disruption for the DES, which adversely do affect on the long-term follow-up. What's the role of imaging for this calcified lesion? There are certain limitations of angiography to look for whether there is a calcification or not. See, angiographically you can very well define moderate to severe calcification. Moderate calcification is the one where the radio opacity noted during the cardiac cycle before the contrast injection, and the severe is the one where radio opacity observed without cardiac motion. And it usually do happen on both sides of the lumen. Coronary angiography as a poor discriminator, only 38% of the calcium can be diagnosed with angiography, and rest can be very well detected with a high sensitivity and specificity with the intravascular imaging. The reliance of angiography to guide PCI and define procedure success in severe calcified lesion is associated with a poor short and also the long-term outcome. Both imaging modality, IVUS and the OCT, is able to evaluate the calcified lesion, whether it's an angle or arc of calcification, which can be assessed by both the modality, while the OCT do help in having the idea about the depth of calcification. And this particular table did show about accuracy of various modality to look for. Calcification, if you see the severe calcification, it can be very well assessed by all the three modality. Mild to moderate, it's better to have with the OCT. Deep calcium, again, it's the OCT and the IVUS, and the calcium arc, of course, these two modality do help. If you look into the data about the IVUS do a sensitivity of 90% and 100% is specificity for the identification of the calcification. Comparison to the angiography, the sensitivity is 73% versus 38% with a significant improvement with the IVUS imaging. The OCT do provide, as I already mentioned, more certain things like the calcium area, calcium length, and the three-dimensional calcium volume, which of course is not there with the IVUS. And when there is a need for the calcified plaque modification, if you do have an arc of calcification which is more than 180 degree, thickness which is more than 0.5 millimeter, and length is more than 5 millimeter, these are the various criteria in which condition you are supposed to have some atherectomy device to have an adequate calcified plaque rupture and had an adequate stent expansion. So this particular case, it's a left main filling defect. You can very well confuse it with the thrombus over here, but then IVUS did show a calcified nodule in the left main. So this is about the OCT, and you can very well plan the therapy depending on the OCT finding. So in case it's a lipid or fibrotic plaque, you can go ahead with the direct stenting or the balloon dilatation followed by stenting. Moderate calcification, of course, it's a semi-compliant balloon or the NC balloon, and those with a high calcium score, there is need to have an ablative therapy, whether it's a rotational, orbital atherectomy or the IVL therapy. These are the scoring system for the OCT imaging. So in case the calcium thickness more than 0.5, it's a 1 point, arc more than 90 to 180, 1 point, more than 180 is 2 point, and the length more than 5 is the 1 point. Any score which is more than 3 is the one where you need to have an aggressive plaque modification with the atherectomy devices. Similarly, you do have an IVUS scoring as well, where again the score which is more than 3 or more than 3 is the one where there is an aggressive plaque modification which is required. Now something about the calcium fracture, what it is. See, calcium fracture is characterized by a gap of the calcium and direct exposure of the calcium to the lumen at the gap site. And why it is important? It is important because it improves the lesion compliance, its distensibility of the lesion, and have an adequate stent expansion at the site. So, this is the OCT image of the particular case. You can very well appreciate this is the fracture. You can very well appreciate the depth of calcium with the OCT. These are the few pictures. Another one is the IVUS. You can very well appreciate the crack in the IVUS, but the depth cannot be calculated with the IVUS. So how it's going to make the difference? The calcium fracture after various ablative therapy. This is the particular study where the MSA was significantly improved in those who had a calcium fracture compared to those patients who didn't have a calcium fracture. This stent expansion index, which is basically a MSA divided by mean of distal and the proximal reference MLA, is also found to be favorable in those with the calcium fracture compared to those who didn't have a calcium fracture. If you look after the long-term 10-month outcome, there is a significant difference in the percentage diameter stenosis, frequency of binary restenosis, and ischemia-driven target lesion revascularization. Now the question comes, is the balloon dilatation effective to have a calcium fracture in the calcified lesion? This particular study, 261 calcified de novo lesion had no dilatation with the NC balloon, no scoring balloon, no ablation, and OCT was done pre and post. See, thickness which is more than 1 millimeter, there is no fracture. Thickness, in case it's on the lower side, less than 2.5, it's a maximum fracture you can appreciate with the normal balloon or non-compliant balloon. Similarly, if you see the calcium arc, if you are in a concentric lesion which is having 270 to 360 degree arc of calcification, there is a calcium fracture. In case it's eccentric, you have a negligible calcium fracture. So that's the importance to know about that. A non-compliant balloon is not so effective in having the calcium fracture and treating a calcified lesion. Either you have to have a scoring balloon or atherectomy device to have the adequate plaque modification prior to stenting. This particular study, concentric versus eccentric calcified lesion, 31 lesions which were treated with IVL therapy, calcium fracture was there in the 71% of the lesion with a good stent expansion in 93% of the patient. And there were the two groups, less than 180 versus more than 180, and it's been found that MSD and the acute gain were similar in two groups. Something about the undilatable coronary stent. Its management is something which is challenging. NC balloon and a very high pressure NC balloon are sometimes ineffective with the high complication rate. You do have a rotational atherectomy, which do have, sorry, my slide doesn't show the references because of some modification in the slide over there, and therefore I am not able to quote various references which I have mentioned across this statement. So regarding the rotational atherectomy, it's able to ablate the stent struts and can fragment the underlying calcium after putting the stent, but then it do have certain complication. Excimer laser with the contrast is another way, but then it's to have a limited availability, and IVL therapy is the another one. This particular study has shown about that it's significantly improved the MSD and also MSA in those treated with IVL therapy and under expanded stent. This particular case, calcified neoatherosclerosis with undilatable in-stent restenosis, you can very well appreciate the markedly calcified in-stent restenosis. So this particular case, NC and the scoring balloon couldn't be helpful for the dilatation, and ultimately it's the rotablation followed by stenting which could give the good result. This particular case of mine, 14-year post PCA, present with chronic stable angina, significant in-stent restenosis of the RCA, 3 balloon of 2.5 got ruptured during the balloon dilatation, did the OCT to look for what's going on wrong. You can very well appreciate the calcification in the neointimal hyperplasia, calcification seat over there. And then it was treated with a flat storm cutting balloon, following which you can appreciate the cut over here. And then it's stented with 2 overlapping stents with a good result. And then sometime with the individual therapy, you are not able to have a good results. Rotablation with the 1.5 bar or the higher bar, and then still the lesion is not dilatable. Either you can use with the scoring balloon or lithotripsy. Rotatripsy is the one, and this rotacut is the another study where the 96 patient with a conventional balloon angioplasty and those with the cutting balloon. And it is found that the 3-year MACE rate is significantly better in those with rotablation followed by cutting balloon compared to non-compliant balloon. And this is the algorithm how to have the management of the calcified lesion. And this has been already talked by Dr. Akasaka. Only thing is the stent malapposition and stent under expansion. I would like to take that post-dilatation with the NC balloon, OPN balloon, and in case it is not effective, it's a lithotripsy which is helpful for the management. And let me show a few cases about the calcified lesion. This is the case of 50-year-old diabetic hypertensive female who presented with the exertional angina, and this is what the LCX which is significant. The LAD is diffusely diseased from proximal to distal part. RCA is normal. You can very well appreciate there is no significant calcium on fluoroscopy, angiography. It's okay. So we did put a stent across 2.538. The proximal parts is somewhat under expanded. You can very well appreciate. And this is the balloon. Proximally over here to Hannah, there is non-dilatable proximal end of the stent, and then the balloon got stuck up when forceful removal of balloon was tried. Both the wire and the balloon came out, and this is what we already had in a dissection at this proximal LED. LED got occluded. Hurriedly we did put a stent across the LCX 3 into 24 millimeter stent, and then with the help of the microcatheter we could cross the LED dilated with a 2.5 millimeter balloon. And then we did try to put the stent just to restore the flow across the LED. 332 synergy not successful, 330 Osira not successful. Then a small stent 2.522 could be deployed in the overlap segment over here, to be followed by 338 Jains in the proximal LED, and the flow was achieved. So this is what the flow across the LED. You can appreciate over here the overlap stent at this particular point, and which is very much under expanded. There is a hemodynamic improvement at this point of time, and then none of the balloon was crossing across 2.515. Body wire was used. None of the balloon could cross it. With the guideliner, we could cross another balloon 2.75, but then further balloon 3 millimeter couldn't cross. And this is what, after having the balloon dilatation at this particular point. So what next? IVL therapy, rotablation. As the normal balloon was not able to cross, IVL is out. So it's a rotablation. We did try the rotablation therapy. This run can very well appreciate what has happened. After having around 5 or 6 run, initially the speed was 170, increased to 190. The bar got stuck up over here. But with the forceful pulling, it came out. And this is the baseline cine prior to rotablation, and you can very well appreciate after the rotablation. So there is a difference between the two. So to a certain extent, we could ablate the stent structure at this particular point, and thereafter we were able to have a dilatation with the NC balloon. And this is the IVUS across the LED, this particular point which is under expanded. You can appreciate there is a calcium arc over here, which is 360 degrees.